We now move ahead with the guest lecture session that's on cardiogenic shock, management strategies 2012 and beyond. Our invited speaker is Dr. Vikram Khatri from Delhi. He'll have 12 minutes for the presentation followed by 3 minutes for discussion. May I request Dr. Chopra to kindly stay on, and he'll be joined by Dr. Shah from Mumbai.
Ladies and gentlemen, I request Krishna CK to please join me on the dais, and Stephen Sealing, please come up, and I also request Dr. KK Kapoor. KK Kapoor, please come on the dais. This is a very important session because we are every day seeing patient of cardiogenic shock, and we have a very important person who has got a diploma from American board. He is a critical care chief in our hospital in Delhi, and he has a very versatile experience, and he is going to show us something very important as to how we can manage cardiogenic shock. Dr. Vikram Khatri, sir.
What we've been doing is obviously improving the myocardial contractility. Sometimes I think maybe too overzealously. We engage in, if the blood pressure is okay, we engage in afterload reduction and reduce the sympathetic tone, and we try to salvage as many organs as we can. On the venous side, we try to offload people by diuretics and obviously help the oxygenation by ventilatory support. Now, the first topic as I want to address is where are we going in choice of inotropes or vasopressors, if I like to say, whether you want to go with inotrope or a vasopressor, and what's the rationale. Well, recently, I think not recently enough, 2010, there was this huge study, original article from New England Journal, which actually compared dopamine, which is our favorite drug these days. Well, especially when I came to India, I found dopamine being used quite a lot, versus norepinephrine. And this was almost groundbreaking in the sense that we've actually passed on traditional knowledge and of medicine along various generations of cardiac trainees that dopamine is the go-to drug. But in fact, these guys had a higher death rate in dopamine group. Dopamine group actually had more tachycardia, more arrhythmias, and norepinephrine seemed to do the job as well. So this is quite important, and the basis of physiology lies in the fact that norepinephrine restores heart vascular coupling better than dopamine actually, and leading to better cardiac perfusion. Next thing we all need to, obviously, because delivery is compromised, you need to decrease the consumption, and what we've been prioritizing is actually increasing delivery. Well, we got to look at the other side of the coin and decrease the oxygen consumption. And the biggest weapon in our armament is non-invasive ventilation. The reason I show you this Cochrane collaboration study is not that you guys don't know what non-invasive ventilation is, but in fact, it is actually better than invasive ventilation. It has shorter ICU stays, and you can actually, if you don't staff, or if you have lack of staff in odd hours, this is a very easy tool for anyone to slap on, and you can actually save patients with it faster and better than invasive ventilation. So if you don't have one in your hospital, please buy one ASAP. Now the other point, obviously we are all in the era of goal-directed or endpoints being measured. I want to talk about monitoring and goals in cardiogenic shock. Where I want to emphasize on that we need to move away from pulmonary artery catheters. It has been shown to have no improved outcomes in the Canadian studies. Actually, they had worse outcomes and complications. And the bigger question I always ask is cardiac output index the endpoint? Really, if you look at energy delivery and consumption model, energy delivery in mammals is directly linked to mass, not body surface area, which we use as heat dissipation, which actually works in non-organic bodies like spheres, but not in humans and animals of different shapes and sizes. So body surface area is a very poor denominator, and there's no one cardiac index which is better than any other cardiac index. Who's to say 2.2 is good for me and not good for the other person? And so if anybody hasn't read it, I suggest there's a very important, very good review on the importance of metabolic rate and the folly of body surface area, because the whole game is energy delivery and consumption. So what we deliver it to and what we target is very important. So what do we actually monitor then? I think of cardiogenic shock as systemic illness. So you need systemic markers. You can get oxygen consumption breath by breath these days with volumetric oxygen consumption. You can see lactates. And in fact, in our ICU, we use lactate as the endpoint of cardiogenic shock. You can even use procalcitonin. I know it's more specific sepsis. But recently, in 2012, I came across this article on interleukin. And, and they found that it was the strongest predictor of 30-day mortality, better than BNP, better than lactate, better than other markers, basically. So I think it's a systemic illness. We need to focus on getting systemic markers and treat it as one. Okay. The other thing I really want to harp about is, as a critical care guy, I want to get these guys out of shock ASAP. And sometimes I get the answer, and I think a lot of you do as well, or let him stabilize a bit. Well, I think the point I'm trying to make here is that we've got to be aggressive in taking these patients to the cath lab and opening opening their vessels and getting them out of the spiral of ischemia. Because if you don't do that, the outcome is really, really poor. And if you do that, there's another article now, which was out of last month, I think, intra-aortic balloon support of myocardial infarction. Now this is with or without cath. So if you do IABP or not, it doesn't matter as long as you've taken them to the cath lab right away and opened the vessel. So maybe you actually escape from complications of IABP. So that's just to make the point that early revascularization is crucial. So this is, again, this is what I come across day in, day out. It's not cardiogenic shock because the patient's physiology is in shock, but we've created that shock. This is a rather busy slide, but I can show you what we do. Sometimes we have RV infarction and we load them with volume. There's deviation of septum, and it impinges on the left side and makes the cardiac output go down even more. And the worst thing is diuretics. Now, the point here is, it's not always volume overload. It's redistribution of volume. And most times I find redistribution of volume, which goes away with positive pressure ventilation, NIVs, and in fact we end up giving 4, 5, 6 liters of fluid, and patients, we not only salvage their shock, but we actually salvage their other organs. So you don't have to sacrifice kidneys always if you actually give, if you treat cardiogenic shock. So you got to be careful on blocking that compensatory tachycardia with the beta blockers. I mean, you got to choose these agents very, very carefully. Even nitrates can do a lot of harm. So I mentioned this earlier, heart and vascular system coupling. Now, heart and vascular system works in tandem. As you all know, physiologically it makes sense when you treat cardiogenic shock, you got to target both the systems. Now this is the current model of cardiogenic shock. If you look, there's a lot of emphasis on systemic inflammatory response, which leads to vasodilation, and that leads further down to ischemia and loss of coronary perfusion pressure. So perfusion, as you know, has two components, systolic, diastolic. Diastolic is maintained by the intact vascular system reactivity, which gets compromised in a shock state. MAP has actually, at lower heart rates, have more component of diastolic blood pressure, which is from the vessels. And organ perfusion pressure, I think like an intensivist, is MAP minus the CVP. So you have high CVP in shock, low MAP, and your organs die. So it's very important that you focus on aggressive maintenance of diastolic blood pressure, because it not only perfuses the organs, but it also perfuses the coronaries, because your LVDP is high. So the higher the diastolic blood pressure is, you got it compensates for that basically. And plus, do not use alpha agonists to achieve the diastolic or ADH analogs like vasopressins. Mechanical devices. Obviously, there's a lot of talk. We obviously don't want to tinker with the drugs. We go and put in these devices, but these devices come later in the grand scheme of things. We are all very familiar with IABPs. LVADs are coming in a big way as destination therapies and also as a bridge to transplants. Now, Tandem Heart and Impella are two percutaneous devices which have shown a lot of promise, but their outcomes are still as good as IABP. But just to emphasize, bridge to transplant, if you use these devices early and judiciously, 74% of your cases go to transplant and 87% of them go home. There's ECMO, but you have, it's a lot of cost concern, especially in India. And IABP versus percutaneous LVADs, there's no difference. That's the other thing I want to emphasize, because before you go and buy an expensive one, actually. So this is my new paradigm on treatment. This is how we attack cardiogenic shock in our intensive care. We do a rapid focused echo, which pleases Dr. Chopra a lot, but this is actually very, very crucial. The second thing we do is, so with the echo, you find out whether it's left heart, whether it's right heart, whether it's fluid responsive or not. We reduce oxygen consumption. We check for fluid responsiveness. A lot of shock is responsive to fluid. Blood pressure comes up. Then we go on norepinephrine. Then we talk about IABP, and then we go ahead to revascularize people.
So we can continue.
Thank you very much.
Continue further. How many slides more?
The last slide.
Last slide. Okay.
So this is our algorithm, basically. If I can go back, the last slide. So this is our algorithm, and we promptly, aggressively revascularize patients. So this is how we treat patients. And we don't always shy away from fluids. As I emphasize again, it's a redistribution of fluid rather than overload, mostly. So thank you very much.
Thank you. I think, Vikram, you brought a very important point. And cardiogenic shock is in every critical care unit, whether it may be septicemia or a hypovolemic or a hypervolemic or a renal failure, a number of causes are there. And I think he brought a very important issue about the lactate estimation. And the second thing which he has pointed out is interleukin 6. I think all these things are to be practiced now. If we really want to prognosticate our patients, we must estimate lactate levels. And he used repeatedly re-emphasize redistribution of fluids. So please don't give over diuretics. You further harm the patient. And the role of beta blockers have to be also very meticulously planned and assessed. You see, if we manage our patient meticulously, we can give a lot of morbidity and mortality benefit. I think it was a very nice talk. Sonia, you want to give any comment?
Well, as the director of pediatric cardiac ICU, I think it's not very different from the things that we implement in the pediatric cardiac ICU, and that we are turning to CPAP more than early ventilation because of prolonged stay in the ICU and more liability to infection and problems. So thank you for pointing this out.
I saw it at a very practical lecture. I mean, this what you have pointed out, that rapid echo, just to see what's going on, what you will do, is very important. Again, as Dr. Chopra has pointed out, the lactate level is very important. The interleukin 6 is very important. So we will take this into considerations, and this is very practical, as I said.
Yeah, I think that was a very, very lucid lecture. And I was impressed that you emphasized that we should not shy away from giving fluids, to these patients, because many of these cardiogenic shock patients do improve with fluid therapy also. Another important thing that I wanted to say is that many of the cardiogenic shock who comes post-MI, and particularly those who come after 24 to 48 hours, they have mechanical causes of cardiogenic shock like severe mitral regurgitation or interventricular septal rupture. And therefore we need to address those along with the treatment of cardiogenic shock along with. Otherwise these patients have a very, very grim prognosis and are not likely to improve if you don't treat those things.
Thank you, Vicky. Kapoor?
Yeah, what I wanted to ask was that if the LV-EDP estimated by echo, CVP estimated by echo, if they are high, then will you give diuretics or not?
Vikram?
I think there are a couple of assumptions here. One, CVP, in my readings, CVP is not truly always reflective of A, volume status, and then it doesn't become reflective of what happens to CVP when you actually give volume. So I think the question I ask myself is fluid the answer or not? So there are dynamic parameters to do that these days. There's IVC collapsibility, flow across the aortic valve. I think those dynamic parameters would tell you what will happen if you do give fluid and what will happen if you don't. So answer lies there. And estimation from a sonologic, I think I am not expert enough to comment on that, but I feel there is a little, it's sort of a circuitous route to attain those values. So,
no, as far as I think is that cardiogenic shocks are of two types. In which the volume is relatively less, in some the volume is relatively more. If the volume is high, then you are overloading the patient further.
That's correct.
So in that case, would you like to give a diuretic or just to give fluids only? If you give fluids, you are overloading the patient.
Absolutely.
Absolutely.
Krishna?
Well, it was a very good practical lecture, but I was just, I've seen a lot of patients you put on milrinone in patients with cardiogenic shock. Can you put some light on that?
Well, the concept behind milrinone is if there's a myocardium which is functioning at the borderline of substrate delivery to itself, and if you use inotropes or catecholamines, they tend to increase myocardial oxygen consumption. So that puts that already at risk area, it might just push it over the edge. Milrinone has that advantage of not increasing the myocardial oxygen consumption. But the risk of arrhythmias is just about the same as dobutamine, dopamine. The only theoretical benefit I see is using the physiological mechanism of the drug. Although I can't give you any clear-cut studies on that because I don't think there is any.
Let's give a big hand to Vikram for his outstanding presentation. And with this, I'll hand over the token of appreciation on behalf of the organizing committee. Vikram, you just stay on. I'll request Hala, Sonia, and Stilling, and VK and KK Kapoor, please join me.
Many congratulations, Dr. Khatri, and thank you very much for being here with us to enlighten the august audience in the field of your concentration.